Well, thanks for everybody's patience as we work through our AV system. We'll start with introductions. Just as a reminder, next week we'll be hearing from one of our infectious disease specialists, Dr. Paul Sadev, a well-known teacher to many of us. He'll be discussing viral villains in an era in which we've had many new and interesting and sometimes scary viral infections that we would love to learn more about. Today we're joined by Dr. Craig Riley. Dr. Riley serves as Associate Medical Director for the Primary Care at the Vancouver Clinic. He earned his medical degree from OHSU and then did internal medicine residency and served as Chief Resident at Providence Portland Medical Center, where he also joined the general medicine faculty. Dr. Riley's skill and passion for teaching has carried over from his chief year, and he's been quite capable and willing to share his expertise in multiple areas at lectureships and conferences like this. He's passionate about patient care, particularly evidence-based and patient-centered medical decision-making, and is always careful to as well bring patient education to the table. I understand Dr. Riley enjoys quite a busy life outside of work too, with 3 young boys, so I greatly appreciate his taking his time to come here and speak with us at St. Vincent's. Fascinating topic today.
Good morning. Can everybody hear me okay? Thanks for having me today. I'm really excited to be here and be part of the conference series here. This is a subject that has come up a variety of ways in my life, not in personal ways, but in very professional ways about discussing how best to think about the influence that marijuana has on our patients and on their physiologic consequences. So the focus of the discussion today is going to be a lot about how do we think about what we know from a physiologic perspective, and how can we counsel our patients and have a good conversation with them about the impact of their marijuana use. And so some of our objectives today is to start with some basic language to kind of set the table. That's, I'm finding, familiar to some people and not so familiar to others, so we'll sort of normalize that. I'm going to talk about side effects of marijuana use from a variety of perspectives, physiologically, with 4 specific system-based concerns, so neuropsychiatric, cardiovascular, pulmonary, and the GI tract. We'll talk about the limited evidence for benefits and talk about how to take a good marijuana history for our patients. The takeaways I'm hoping you can walk away from this talk with is that there are side effects. These side effects matter, and as we think about how our patients are going to be affected by their marijuana use, thinking from a system perspective I think is appropriate. And really that is directly dependent on the route of administration. So I'm going to say frequently today that the route of administration definitely matters, and having a good idea of how your patient uses marijuana influences your discussion with them. There's certainly some evidence for symptomatic benefit, and we find that most impressively in neuropathic pain, although that evidence, like all evidence for this topic, is fairly limited. And unfortunately, it's not a medicine. This has come up a couple of times as I've given this talk, but I think one day it could be, based on what we know about the endocannabinoid system. So I'd like to start with a case. This is a 55-year-old woman who comes to establish care. Her past history is notable for a myocardial infarction at the age of 37, and she underwent angiography that demonstrated clean coronary arteries. She struggles with frequent ER visits for acute episodes of abdominal pain associated with nausea and vomiting, to the degree that she's had 14 abdominal CTs in the past 2 years. She has a recurring productive cough that is worse in the winter months. Now, as sort of stunning as that number of CTs may seem, this is not an uncommon presentation that I see as a hospitalist. Her principal complaint today is that she struggles with depression, and unfortunately, her doctors that she's dealt with in the past never seem to know how to help her. She denies any illicit substance use, uses marijuana daily for chronic pain and nausea, and is hoping you'll sign her medical marijuana card, or what now amounts to essentially a waiver or an attestation as a physician that this is someone who would benefit from marijuana. Her physical exam is normal, so how do we take an effective history and counsel her about her marijuana use? So it starts with our knowledge of the endocannabinoid system. And we know from limited animal studies that we have a good distribution of cannabinoid receptors throughout the body. When it comes to the distribution, I think it's important to have some understanding of where these different receptors are distributed. So the cannabinoid 1 receptors, which bind THC fairly effectively, and the cannabinoid 2 receptors, which bind cannabinol more tightly, are distributed differently throughout the body. So the CB1 receptors are much more CNS distributed, and the CB2 are much more internal organ, GI tract, etc. distributed. Cannabidiol, which you'll hear about frequently as a possible therapeutic source, and our learning about which combination of these different components in marijuana are more effective for different syndromes is certainly at its infancy. But you'll hear about cannabidiol frequently as a possible therapeutic target. Sort of loosely binds to both of these receptors with different affinities. In terms of the endocannabinoid system itself, the predominant ones that we've identified are anandamide and 2-AG. The ultimate overall effect of these tends to be promoting weight gain, insulin resistance, and we found that there's an overactivity piece associated with obesity. There are then exocannabinoids, obviously the combinations of different pieces in marijuana that we're still learning about can be seen in a variety of different combinations and in a different set of concentrations throughout a variety of different products that you can find in most marijuana shops in Oregon. What we do know about the components that are most predominantly included in higher concentrations is THC tends to be more psychoactive, cannabidiol tends to be more anxiolytic and antipsychotic, so almost a different opposing effect there. But then there are also exocannabinoids that can be quite toxic, such as K2 and spice, which I'll get to in a minute. This is a very busy slide designed to just show that there are a number of therapeutic targets that have been looked at in terms of the efficacy of things like THC, cannabidiol, and a variety of similar substrates. So a lot of these are CNS associated, so Parkinson's disease, Huntington's disease, Alzheimer's disease. For example, we've seen that delta 9 THC can have an effect on the acetylcholine esterase induced A-beta aggregation. So there are a number of, again, physiologic and animal studies that suggest that there's a physiologic impact here that we have been unable to really capitalize on in terms of clinical studies thus far, in large part because of the difficulty around this still being a Schedule I drug. In terms of consumption, just to kind of level the playing field here, sativa, the cannabis sativa plant and the cannabis indica plant tend to be marketed very differently. So sativa tends to be associated with more of a active, aggressive high and is marketed as sort of the plant for the mind, and indica is more of the plant for the nighttime and the plant for the body. So you'll tend to see that in some of the marketing. In terms of the language around this, leaves, stems, and tops from the plant are used in cigarettes. That's where the term joint comes from. Or tobacco leaf wrapper from a cigar. That's where blunt comes from. Hashish is the resin or exudate from the underside of the leaves, and that can be a more potent concentration. Sensimilla is also very potent. This comes from the flower itself, which is born out of the sativa plant. And then hookah, pipe, bong, e-cigarette, and vaporizer are all different ways to essentially inhale any of these concentrations. Hotboxing is a term that was very common to me in college, not because I hotboxed, but because I heard about it a lot. But I found in these talks I need to explain that. So essentially hotboxing is using marijuana in an enclosed space, often in a car. And so as you hear your patients talk about that, that's essentially what that means. There's also boosting, which is adding to tobacco or other drugs, and this becomes especially important as we think about the confounding of a variety of studies that we have, especially these observational cohort studies that unfortunately include a lot of other drugs in the mix, which makes it difficult to really piece out the effects of marijuana itself. And then dabbing is using butane hash oil, which is a very potent, very highly concentrated version of marijuana that can be very explosive and very toxic for those who try to prepare it at home. Sherms are a term that you're not going to hear a lot of. This sounds like maybe the most toxic thing you can do to your body. It's a joint dipped into PCP, dissolved in formaldehyde, dried, and then smoked. So watch out for your patients who are using those. Edibles are an important part of this conversation. So they were legalized in Oregon as of June 1st. They've been legal in Washington for a longer period of time. And when Colorado went to legalization, edibles were part of that allowance. There's legislation currently in place proposed to ban, except for the liquids and the lozenges, which are thought to have more of a therapeutic effect. The problem with this, of course, is that dosing is really challenging. Unfortunately, they are prone to overdose. So for example, if you've got a typical marijuana patient who's used to essentially accomplishing an immediate high or an immediate effect from inhaling marijuana, and then goes to an edible version where they have to have GI absorption to result in the effect, there's a delayed effect compared to what they're used to. And because of that, they think essentially what they've taken doesn't work. So the dose may be a quarter of a cookie, but they don't see the impact immediately, so they take a half a cookie and then a full cookie, and then an hour later it all hits them. So the dosing can be challenging for that reason. It's also challenging because it's in a different version. And as you can see here, it's really, really challenging when it comes to children. So these may be the marijuana-infused gummy bears. These may be the marijuana-infused gummy bears. There's no way to tell. And so it's very easy for a lot of the marketing to children to take place. We've seen already some legislation in Oregon along those lines in an effort to cut down on the marketing to children. So specific names recently in the past couple of months have been banned essentially because they sound too much like things that children would be interested in. So there is some approach, at least in Oregon, to try and be very careful about regulating this version of marijuana. The efforts the State Department has taken to try and curb that not only includes changing the naming, but also having some attention to the purity and the lack of pesticides in this material. And so you're seeing more recently a lot of attention paid to state testing laboratories and making sure that a lot of the product that comes through, especially that being certified by the OLCC, is tested in state-run laboratories. So there is more regulation, I think, in Oregon than there is in some of the other states that have legalized, and you're going to start to see more and more of that. The challenge about federal regulation is that it still remains a Schedule I drug. So that was recently reinvestigated back in August, and at that point it was still determined to be a Schedule I drug. There were some allowances made about how much could be used for testing and for experimentation, but unfortunately it still is considered a Schedule I drug, making it difficult to regulate, difficult to study. Other cannabinoids to be aware of with respect to your patients and their conversations. Dronabinol is FDA approved for AIDS anorexia. Nabilone is FDA approved for nausea and vomiting from chemotherapy. Nabiximol you're not going to see a lot of here. It's approved in Canada only for cancer pain, spasticity, and MS-related neuropathic pain. And then K2 or Spice is the illegal version that you're going to find on the streets. This is really what the poison control here is the most about, is these illegal synthetic marijuana concentrations, which can be very high in a lot of these formulations and can come with toxicity. In terms of some of the numbers around the state of Oregon, and then I'll touch on Washington as well, given that we're so close to the border. As of June 30th, there were 147 recreational dispensaries. There are more now. Medical marijuana dispensaries can also sell recreationally until December 31st, at which point every group has to be converted over to either recreational or medical marijuana. So those groups that want to convert, meaning those medical marijuana dispensaries that want to be able to sell recreationally after December 31st, are involved in a process currently of getting associated with the OLCC and becoming able to do that. That association allows them to lower the tax on how much they can charge people who come in and buy marijuana, and gives them some additional benefits. So you're seeing a lot of discussion around that. Again, that association with the OLCC is specifically subject to specific testing in state-accredited laboratories. $25.5 million in taxes were collected in the state of Oregon from January 1st to January 30th. Their original projection for the year of 2016 was $8.5 million. By the end of September, they had reached $40 million. So even at this point in June, they were projecting an annual revenue from the tax revenue of around 35, and they had exceeded that by the end of September. So you're going to see more of this, not less of this, moving forward in the state of Oregon. The price per gram on the recreational market is taxed. That's at 25%. That is going to be cut down to 17% for those groups that associate with the OLCC. You're going to see here in Oregon a much lower price, the $10.96 per gram on the medical market, than you are in the state of Washington. A lot of the dispensaries in Washington have shut down, in large part because they are subject to a higher tax. So a lot of people who are aware of the difference can get their medical marijuana attestation in Oregon, come to Oregon and pay a much lower price than in Washington. Again, as of June 1st, edibles, extracts, and topicals are available. Girl Scout cookies was considered the top-selling strain of marijuana in Oregon. Unfortunately, that name had to be changed because, as I said, there was legislation around making sure that we don't use names that can attract children. But Girl Scout cookies themselves, as you can tell, are also very popular in Oregon. Oregon marijuana by the numbers continued. So before legalization, 1 in 10 adults used marijuana. There's much more than that now. There are also things I think that are interesting around the state, including the fact that a lot of counties have opted out of allowing licensed marijuana businesses. There was recent legislation in this last set of results around being able to ban marijuana dispensary locations in their district, and a lot of counties specifically rejected that ban because they wanted to be allowed to participate in some of the tax revenue. So I think because of that, again, and because the tax revenue has been so high, you're going to see more and more counties around Oregon begin to adopt this. Oregon is also unique in terms of penalties for marijuana-related offenses. In Florida, possession of 20 grams is still a felony. There's actually a lot of marijuana-related convictions, prior convictions that are being set aside in Oregon specifically. That's something Oregon has been a leader in. There is still the opportunity for landlords to prohibit cultivation and consumption on their property, but allowed in part of the legislation is a lot of patients can grow their own marijuana, especially medical marijuana. You still can't use marijuana in public. Washington marijuana, I'll run through this briefly. They legalized in 2012, but have had home growing allowed since '98. As I talked about, it's much more expensive, especially medical marijuana, much more expensive in Washington than in Oregon. They are able to join a voluntary state database and exempt them from sales tax, which is sort of what Oregon's doing with the OLCC, but there's still quite a high state tax, which is again why it's so less expensive here. In terms of qualifying a medical marijuana patient, I get this question often. They, in the state of Washington, have to have one of these conditions. In the state of Oregon, they need to have one of these conditions or any medical condition or treatment that produces cachexia, severe pain, severe nausea, seizures, or persistent muscle spasm. There are more allowances under this caveat in Oregon that allows people to qualify for medical marijuana. I don't have a slide of this, but it's a very easy form to find on the internet. That is the attestation form. So if you want to attest for your patient, you simply sign the attestation form, sign that they do qualify for one of these conditions and therefore qualify for medical marijuana. It's very clear on that form, and this is the discrepancy a lot of people ask about, that this does not constitute you prescribing marijuana, which would be not allowed under the federal government. So there's a clear difference there. In terms of the discussion I have with providers around whether or not they can or should attest for patients, it really, I think, comes down to a provider level decision and your conversation with your patient. I don't think there are significant legal ramifications if you attest for your patient in the state of Oregon or Washington. All right, moving on to the state of the evidence and some of the physiologic ramifications of marijuana use. So we are getting increasing well-done prospective data, but it's still very limited. Again, most of our data comes from the physiologic studies, but there's a lot of additional investigation that is needed. The confounders are many. So you'll see there are many confounders around the lines of socioeconomic status and mental health that come up time and time again. But there are also specific confounders with the different types of substances that patients tend to use. So the association between marijuana use and tobacco use is very high, and especially when we're talking about lung cancer and other pulmonary complications, there's a significant impact there, confounding from the tobacco. Additionally, concomitant alcohol use, illicit drug use can play a role. And we're seeing escalating cannabinoid concentration in marijuana. So this comes from the New England Journal in 2014. The potency has risen dramatically over the past 15 years, making it really difficult to know how to interpret the various studies that have come even before 5 years ago. I'm going to touch on, again, these 4 organ systems. First, the neuropsychiatric. So there's good data to support the addiction hypothesis and the gateway drug hypothesis. There's also altered brain development that I'll touch on briefly. There's definitely large population studies suggesting some cognitive impairment along the lines of poor educational outcomes and increased risk of chronic psychosis disorders. All of these neuropsychiatric effects are strongly associated with initial marijuana use early in adolescence. So it's that patient who started using early in adolescence, was using frequently, using a high concentration or a large quantity, that is going to have most of these neuropsychiatric impacts. And those are the patients you want to think about with respect to their current use. In terms of active brain development, the endocannabinoid system itself is actively developing during adolescence. So that includes these areas of the brain, especially things like the hypothalamus and the basal ganglia, and certainly also the amygdala with respect to thinking about how to cope with certain life stressors. You can imagine how that influence could be detrimental. And then the hippocampus and the effects on the memory have been well documented. In terms of the autopsy studies that they've done, they found actually fewer brain fibers in specific brain regions, especially in those who are chronic marijuana users. And I think some sobering facts that came out of this, especially as we are concerned about those younger patients using marijuana, that's a fairly high number of patients age 12 or less who have experimented, and I think a very high number of 12th graders who use daily. So daily use is correlated much more consistently with these neuropsychiatric effects, and especially when we're talking about those who are very impressionable and who are having actively developing brains, this is a very concerning number, and that doesn't take into account those who have dropped out of school. So this is a study that only included those still in school who are using on a daily basis. Prenatal exposure, this work comes from Ken Rosenberg up at OHSU. He did a very nice large-scale meta-analysis review of the studies that have looked at prenatal exposure and the ultimate implications of that. The unfortunate consequence of this, as is the case with most of the data, is that it's very limited, and there are multiple confounders associated with this data as well. But there are essentially 7 large studies that have looked at this. The majority began pre-1995. There are 2 large-scale studies that are ongoing even today, and with most recent results in the past few years. Again, the conclusion is difficult because we're not sure whether the effect is the marijuana effect or the population, the mothers themselves, and the socioeconomic status of some of these situations. We also know that mental health can be a very powerful confounder in all of these studies when it comes to the outcomes that are reviewed, and certainly those are not controlled. There are also major methodologic flaws with a lot of these studies. But if we look at the sort of, as I reviewed this data, 5 most influential studies, the Ottawa and Pittsburgh studies are the ones that have been ongoing for the longest period of time, and they've demonstrated deficits on executive function tasks, executive function IQ, and mood, respectively. And then the Jamaica, Avon, England, and Cleveland studies, which are shorter in duration and have looked at more limited outcomes, have not found significant deficits. So this is a microcosm of what we find in the literature with respect to marijuana. There are a lot of mixed results, and unfortunately we end up with unclear conclusions, but we always end up with one of these significant studies or well-done studies, at least in that range of the spectrum, that causes us to believe there's some sort of an effect, and there's likely some sort of influence there that is not well measured at this point. In terms of cognitive impairment overall, this was, I think, a nicely done study. This came out in a large-scale review from Neurology in 2012. This was a 2004 study that looked at processing speed in smokers and non-smokers. So they started with a processing speed task and looked at chronic marijuana smokers compared to those who didn't smoke, and they found those who were chronic marijuana smokers had significant slowing of the processing speed. Then if they were allowed to sort of smoke their usual amount of marijuana, whatever that was, 30 minutes later, their processing speed normalized. suggesting that there is a deficit that develops with chronic smoking, which normalizes during acute intoxication, lending credence to that historical anecdote that those colleagues of yours in high school who used marijuana before the SAT and did better was probably true, especially if they were chronic users. When they looked at a number of different impacts here, especially looking at the time course, so acute intoxication versus the residual effects versus the long-term effects, attention and concentration, consistent with the prior study I just showed, is worse with abstinence and improved with use. And that's true in the acute state and in the residual state. But over the long term, the effects wane. So attention and concentration largely normalizes if they're abstinent for more than a month, essentially. With decision making, you see a similar impact. Acute intoxication is associated with decreased response speed, decreased or prolonged latency, and you'll see that in some of the motor vehicle accident data I talk about. But the residual effects, and especially the long-term effects, is largely improved. The same case can be seen in a variety of other areas that were investigated here, suggesting that with abstinence, a lot of this normalizes. Now, the one caveat to this is that, again, those patients who are chronic marijuana users, especially in adolescence, tend to be more likely to have long-term consequences from a cognitive perspective. Madonna in 1994 said that she used censored language, which in 1994 was a pretty big deal, on David Letterman because she smoked a joint before coming on the show. I think that was probably dismissed in 2009, but now we have some evidence to suggest her statement may have been evidence-based. In terms of risk of motor vehicle accidents, we have seen significant associations in simulation studies of substantial driving impairment if THC is detectable at all, and we see a dose-dependent effect here. So much more likely to be involved in an accident at the higher THC levels, and 5 times more likely even at the sort of blood alcohol level that we consider illegal. So there are certainly, I think, next steps, legislation to come around being able to test patients in the setting of being stopped in a motor vehicle situation. In terms of psychiatric disorders, inherently it's difficult to establish causality. There's certainly some increased association seen with anxiety and depression, as well as an earlier onset of psychotic disorders, but these are very difficult to control for. And whether that was associated with a precondition or with the marijuana use itself is very difficult to identify. From a cardiovascular perspective, this is one of my favorite studies along the lines of marijuana use. This is one of the few human studies that we have. This came out of England in 1972 and reflected the cardiovascular effects of marijuana smoking. It was a 10 healthy volunteer study that had a fortuitously presented opportunity during a recent trip to Asia. And this was in the New England Journal. They essentially measured limb blood flow with venous occlusion plethysmography while they did a couple of tasks, which I'll cover on their next figure. They looked at a number of vital signs, including rectosigmoid temperature, which apparently is more accurate in England than other temperatures. Before, during, and after a 3-minute period of smoking a marijuana cigarette. So they found that mean heart rate increased. They found that blood pressure increased slightly, and that was in correlation with the increase in mean heart rate. Respiratory rate and temperature did not significantly change. They saw blood flow increase as expected with heart rate, so commensurate with the amount of increased heart rate, but primarily to the forearms and calves, so to larger vessels, not to smaller vessels in the hands. This was their only figure in the study, their sort of figure 1. And it's kind of difficult to tell here, but A and B represent different tasks that these 10 healthy volunteers had to participate in. So prior to smoking, the tasks included a cognitive task, and I think that was A, and a task that essentially was plunging your other arm that's not being measured into a vat of ice cold water. So you can see that blood flow measured in the other limb, whichever limb they were measuring at that time, decreased with respect to both of these tasks. And then after the marijuana smoking occurred, they redid the tasks, including the B task twice, and were shocked to find that there was no change in the blood flow with either the cognitive task or the putting the other limb into ice cold water, suggesting that essentially there is no interest in participating in a cognitive task when they were intoxicated, and potentially that their body was not that interested in appropriately vasoconstricting elsewhere when they were high as well. Now, there are cannabinoid receptors seen throughout the vascular system, so there's some suggestion that that's why we see a higher incidence of acute MI in patients who have recently used marijuana. The acute MI associated with marijuana tends to be seen in a younger population and is more of an atypical presentation. So it's not usually associated with those patients who have pre-existing coronary disease, although certainly those with pre-existing coronary disease are probably at higher risk. There is a temporal relationship. So in that first hour after using marijuana use, for those patients that they reviewed in this case series, there was almost a 5-fold higher incidence of acute MI in those who use marijuana. And we've seen a similar temporal relationship in cases of stroke associated with marijuana use. I actually recently saw a patient who came into our hospital in Vancouver who had used marijuana and had a case of syncope and ultimately demonstrated approximately an hour's worth of essentially posterior stroke symptoms as well as an elevated troponin. And this was immediately 15 to 20 minutes after using a marijuana cigarette that he had never used before, suggesting that there may have been a vascular effect directly resulting from the marijuana use. There's also a study that has demonstrated increased mortality in marijuana users versus non-marijuana users after hospitalization for acute MI. So what is the possible mechanism here? So if we combine those studies with that single human trial that was not very well done in 1972 in England, we see that the sort of most likely hypothesis here is that there's some sort of deleterious effect on the coronary microcirculation. So some sort of vasoconstrictive effect that ultimately results in an acute MI. It's not thought to be related to any acceleration of atherosclerosis for those patients who are using marijuana, although again, we have to be careful to factor out tobacco use because obviously that will accelerate atherosclerosis. A direct increase in myocardial oxygen demand likely contributes. That's probably from the increased heart rate that we see in marijuana use. And then there is a higher risk associated with those who already have coronary disease. But again, we're so limited by what data we have. This is essentially all we have coming out of human studies. There have been case reports of sudden death, VTAC, cardiomyopathy, and CVA. And we've seen on some imaging studies, in case studies, MRA results that have demonstrated segmental vasoconstriction in the hour after marijuana use, correlating with patient symptoms. So again, these are case studies. We don't know exactly what the effects are, but it's clear, based on our knowledge of the physiology, that those cannabinoid receptors exist in the vasculature, and some of these case studies, that there's some sort of circulatory defect that takes place here. Moving on to the pulmonary system. So this is the situation where I think the route of administration becomes really important. It really matters as we think about the different ways our patients can use marijuana, especially with respect to the implications that we think about a pulmonary effect. So these are all the different inhalation methods that you can use. The hookah pipe is certainly popular here in Portland. That's not to say that the blunt or the joint are not. But you see these pop up in various restaurants and other settings around Oregon, especially in Portland. And then there's more popularity associated with the e-cigarette, the G-pen, and the vaporizer. So in terms of the pulmonary mechanics, what we know about the effects of marijuana is that forced vital capacity actually improves. And the thought here is that these patients are so used to taking such deep breaths that they actually train themselves to have a better forced vital capacity. There is a dose-response association seen in reduction of FEV1, especially for those who are heavy prolonged users. But the question, of course, then becomes, is that a tobacco effect? Because so many of these marijuana users roll tobacco with their marijuana in their joint. When we looked at joint years, so greater than 30 years of exposure, and this was looking at lung cancer, we have seen an association with increased incidence of lung cancer, as well as several other cancers of the aerodigestive tract. But the really interesting thing here is if you factor out cigarette smoking and tobacco use, the association disappears entirely, suggesting again that it's not marijuana that could be contributing to these cancers, it's more likely the concomitant tobacco use. So part of that is that it's mixed together, and part of that is that so many people who use marijuana also use tobacco. So I guess the bottom line here is if you're assessing the pulmonary effects of your patient who uses chronic marijuana, really focus back on that tobacco use as potentially, from a pulmonary perspective, the more harmful substance. In terms of chronic bronchitis, there's actually really good physiologic data to support why this happens in patients who are chronic marijuana users. So we see increased mucus production because there's goblet cell hyperplasia, and the thought is that those goblet cells actually have cannabinoid receptors associated with them, leading to an overproduction of those. And then we know that there's impaired mucociliary clearance for those who are inhaling marijuana. We also see an increase in the alveolar macrophages because there is an inflammatory response. But then we also see impaired phagocytosis and increased apoptosis on those macrophages because they actually contain cannabinoid receptors themselves. So you've got more volume, more response of the macrophages coming to the inflammatory site. You've got decreased ciliary clearance, and then you've got increased apoptosis of all that stuff coming into the lungs, ultimately leading to more chronic bronchitis symptoms. So the coughing, especially the early morning coughing, the shortness of breath, and everything associated with that has clear physiologic association with the cannabinoid receptors themselves. The vaporizer is a very common subject of conversation amongst these patients. So one of the things you're going to learn if you delve into this conversation with your patients is that they are more informed than you are when it comes to marijuana use. The amount of information on the internet about marijuana use is staggering. And one of the favorite subjects of marijuana proponents is countering or debunking all of the perceived medical facts associated with marijuana use. So one of their favorite subjects to jump to is the vaporizer, because there's a lot of data on the internet suggesting that the vaporizer is safe, meaning that it doesn't come with the same toxicity associated with the byproducts of using a joint or a blunt or anything associated with tobacco. The vaporizer itself is thought to be effective at remaining cool enough to avoid the toxins from combustion, but yet hot enough to be able to release the marijuana into the lungs. And so there is a Facebook study that looked at 7,000 people who self-reported respiratory symptoms, and vaporizer use predicted fewer symptoms. And then for the larger amounts of cannabis used, the difference between vaporizer use and other methods was greater, suggesting potentially a dose-dependent effect. This is a Facebook study, but you're going to hear patients refer to this commonly as evidence that the vaporizer is safe. My own conclusion about this is the vaporizer is probably a better route of use for inhalational marijuana than other routes, but by no means does it mean that all the toxicity associated with that is eliminated just because you're using a vaporizer. Moving on to the GI side effects. So the GI tract actually has quite a few cannabinoid receptors highly distributed. So the CB1 receptors are associated in the stomach with decreased gastric acid secretion, decreased gastric emptying, as well as slowed intestinal motility. And that comes with inflammation, it comes with decreased emptying, it comes with discomfort, constipation, and pain. There's also CB2 receptors throughout the GI tract that are associated with decreasing inflammation and visceral pain, but they are also associated with decreased intestinal motility, especially if the gut is inflamed. So both of these receptors, highly distributed throughout the GI tract, when agonized, result in decreased intestinal motility, which is going to become important in just a moment. The hepatic effects, and we've seen this only in animal models, is that the CB1 receptors are profibrogenic and pro-inflammatory. The CB2 receptors, which are in lower concentration, can actually even reverse liver fibrogenesis. So again, suggesting there may be therapeutic targets here we're not taking advantage of. But in end-stage liver disease, we see that the ultimate effect is a much higher probability or propensity to develop hepatic encephalopathy. There's also the vascular effects can be really detrimental. So more portal hypertension and more peripheral hypotension, which obviously for the hospital-based clinician is a common conundrum. That happens much more often in those marijuana users. So it's really important that those ESLD patients not use marijuana. It can be really detrimental to their improvement. The overall effect is thought to be progression of liver fibrosis, but again, there may be a therapeutic target there in the CB2 receptors. Cannabinoid hyperemesis syndrome is, I think, well understood by most hospitalists. This is a syndrome that you may see in the office. It comes with this recurrent nausea, vomiting, and gripping or crampy abdominal pain. It was first identified in Australia in the early 2000s. Since then, we do have a good study out of Mayo in 2012 that sort of characterizes this population. The pathognomonic feature is that the symptoms are temporarily relieved with very hot showers or baths. And these patients will often say, the more frequent the shower, the hotter the shower, the better I feel. And the result of that is their abdominal pain, and this cramping tends to get a lot better. Dehydration is common with severe electrolyte abnormalities. So the patient I saw as an intern who had this was running up and down the hall in the hospital begging for a shower because his room didn't have a shower. He came in with a creatinine of 4 from a baseline of normal. He had a calcium of 15. Really impressive electrolyte abnormalities associated with dehydration because it commonly comes from using these hot showers and frequently being exposed to this hot environment. And severe dehydration was a result. It's seen most often in young individuals with chronic use, although as we've seen from this Mayo study that came out in 2012, that weekly use is sufficient to really trigger cannabinoid hyperemesis syndrome. We don't see it in every patient who is a chronic daily user of marijuana, but we do see it in quite a few. Acute episodes tend to resolve with cessation, so simply being in the hospital, if you can keep them away from marijuana, can be helpful, but ultimately they'll go back and use marijuana once they go home if they don't get the appropriate counseling associated with this. The cessation after 3 months tends to resolve the cyclic episodes entirely. The real challenge with that is that so many patients associate the reduction of pain and nausea and vomiting with the use of marijuana because that's how it's advertised and they may have seen that benefit themselves. So they're more prone to use more marijuana when ultimately it's having this impact on their GI tract, slowing their motility and causing their symptoms. From these 98 patients, they found that 71%, the symptoms were worst in the morning. You see a wide variation in gastric emptying times when that's measured in these patients. 58% of patients, without being prompted, independently mentioned these hot baths, and of those 58%, 91% experienced relief. So the hot baths and the hot showers, they may not mention it, they may not notice it because they haven't had that experience yet, but for those who have experienced it, it's quite therapeutic. Interestingly, a third, this was sort of the most interesting piece that came out of this for me, a third of those users reported cannabis use for less than 1 year. So the initial hypothesis was that you needed to use it for 5 to 10 to 20 years to really develop this syndrome, and I don't think that's the case. I have one slide essentially that documents symptomatic benefit. There's a lot of anecdotal evidence about and poorly done observational studies suggesting significant influences in terms of symptomatic benefit of marijuana. As I mentioned at the very beginning, unfortunately, neuropathic pain is really the only one that has shown some promising results. So with respect to glaucoma, there's a transient decrease in intraocular pressure, but there are obviously more treatments that we can use that are more effective. It can be effective as an antiemetic, but again, we have medications that can be more effective. There's actually mixed data on weight gain, which was sort of frustrating for me, that unfortunately we don't see the significant benefit in terms of weight gain in these patients with AIDS-associated cachexia that we would hope to see. But there's no question mood and quality of life improves. So that's certainly, I think, a positive thing in terms of marijuana use. There's promising initial studies as an anti-inflammatory, especially for cannabidiol, that one component that has not been isolated and well studied at this point. But cannabidiol may have real promising anti-inflammatory benefits in rheumatoid arthritis and inflammatory bowel disease. There's actually, this is the area of the literature, of the world of the literature around this that has showed the most promising association is MS spasticity and central pain. So for those patients with MS, I'm actually fairly aggressive about recommending trying marijuana and seeing if it has some association with improvement in their pain and their spasticity associated with MS. With real detrimental, challenging MS, there is solid evidence that this can be effective, especially the oral cannabis extract. Epilepsy, unfortunately, the data is very mixed and mostly appears ineffective, although you'll have a lot of patients with seizure history tell you that it works miraculously well. And then chronic pain, again, most effective based on this Journal of Pain study from 2008 that did a randomized controlled trial crossover comparing marijuana cigarettes to placebo. There's also some evidence for marijuana improvement after capsaicin-induced pain. That's not a very impressive study. And then there's some vaporized effect on neuropathic pain out of the Journal of Pain in 2013. And that's this study. So this was a double-blind placebo-controlled crossover. They looked at vaporized cannabis, and you can see two different concentrations of that. So this was primarily THC that they looked at. And there was a high concentration and a lower concentration that essentially had the same effect. But compared to placebo, there was a statistically significant reduction with a number needed to treat of 2.9 or 3.2, depending on the dose, and a non-statistically significant difference between the low and the high dose, but a major reduction in pain with a low number needed to treat that essentially is comparable to gabapentin. So the place that I've heard anecdotally patients benefit the most from this is some of those patients with really bad neuropathic pain, especially neuropathy, using like a topical, a marijuana topical to try and curb that specific association, specific locally regional impaired neuropathic pain. So that can be effective, and we're still far from understanding the most beneficial way to use this, but the initial studies are promising. So back to our case, I think if you look through all of the different influences that marijuana have had on her medical history, you can see that related to what we've talked about, the MI and the depression are probably associated. The direct result from marijuana is probably the episodes of nausea and vomiting, leading to all these unnecessary CT scans because she probably has cannabinoid hyperemesis syndrome. There's no question the chronic bronchitis symptoms are probably directly related to the marijuana use. So the next question is, how do we counsel her? I think it's important to know whether they use during adolescence. I think that tells us, especially if we have some idea of frequent use during adolescence, a lot about possible long-term consequences on their neurocognitive issues. How often do you use currently? Because current use and high-frequency use can be associated with some of these symptoms much more often. And what methods do you use? So again, route of administration matters. Having some idea of exactly, especially for inhalational marijuana, what they use most often can give you some insight into what kinds of side effects are likely to experience. Glass pipes have this dangerous glass resin that can be inhaled into the lungs and cause its own independent toxicity. We know that there's high combustion toxicity associated with the hookah pipe. And then dabbing can be very flammable, very volatile. There are reports of explosions in homes and in marijuana manufacturing buildings that are trying to create this butane hash oil because that itself is very explosive, very combustible. Vaporizing, again, is probably the safest route for inhalational use, but we don't really have the evidence to say conclusively that's true. And then edibles can be very unpredictable, although I do think the recent legislation around regulation and really trying to get all these substances through state-accredited laboratories is really good regulation. I think it's important to have an idea about whether they suffer from any of the side effects that we've discussed, and certainly any withdrawal symptoms. So those withdrawal symptoms are going to be more correlated with a higher propensity to continue marijuana use despite your counseling. It's important to know whether they're driving and that they know that there are significant impacts of marijuana use in driving, and then using other illicit substances. There's commonly an association there. Refer for substance abuse if they're motivated, if there's evidence of addiction, if there's multiple substance use, or you have concerns about any of the associated side effects. So takeaways today, there are definitely side effects, neurocognitive, much more commonly in the adolescent population, and much more commonly in those who are chronic daily users. Cardiovascular side effects, especially in that 1 hour after marijuana use, case reports of stroke and significant case studies demonstrating acute myocardial infarction that may be related to a deleterious effect on the coronary microcirculation, pulmonary side effects that are directly dependent on the route of use, and GI side effects, especially for those with end-stage liver disease and for those who have had symptoms of cannabinoid hyperemesis syndrome. Route of administration matters with respect to all this toxicity. There's some evidence for symptom benefit in neuropathic pain, and especially in MS and MS-associated spasticity. Unfortunately, it's still not a medicine, but one day could be with proper testing and proper studies to evaluate that. So that's all I have today. I'm certainly interested in any questions you guys have about this. I know it's a very, very controversial subject, and any advice I can offer, I'd like to. So thank you.
Question about secondhand exposure to marijuana, especially in children. I experienced this on Thanksgiving
Okay.
with friends, and there was a lot of smoke hovering around, and there were little 3-year-olds running around. Does the smoke rise? Are they being exposed?
So the question is for secondhand smoke, especially to very young children, and especially perceiving that there's a lot of use and the smoke may rise above the level of where they're standing. You know, I have not seen any evidence specifically referring to what distance, what concentration, what route of inhalation, what the impacts of that are. I would think of secondhand smoke with respect to marijuana sort of similar to secondhand smoke with respect to tobacco. There probably is some exposure, but the amount and the impact of that, I think, would be difficult to estimate. I wouldn't recommend it. Yeah, please.
Gateway drug? Is it still a gateway drug?
So the question is it a gateway drug? I think, you know, this is always going to be controversial. There's a lot of evidence suggesting that indeed it is. So I have a slide on this based out of that New England Journal study, suggesting that lifetime cumulative probability for progression to illicit drug at some point is around 44.7%. So that's a high number. I think that that's still controversial, and a lot of people will tell you that those studies are flawed. I believe it is a gateway drug based on some pretty well done data, but it's still controversial.
Does it increase alcohol use?
I don't know. I think we see a high association with, so the question is, does it increase alcohol use? We see a high association between those who use illicit substances and use alcohol, but I have not seen evidence specifically referring to that. Yeah.
So this was great. We decided as the sort of faculty group for the resident clinic
Right.
that we were not going to do attestations. We just didn't feel like we were ready. We didn't have enough evidence. And so kind of what are your thoughts on that? That's what I'm thinking. One of my residents is here, and we had somebody yesterday who was all in a tizzy because has to pay $200 just to go get the attestation
From somebody else, right?
from somebody else, and you know we're his doctor.
Right.
On the other hand, he has chronic arthritic low back pain,
Right.
and I didn't see any evidence
Right.
to support that. So
Right.
what do you recommend for us?
Yeah, so the question is for especially resident clinics that make a decision about whether or not to allow attestation, and especially I think on an individual provider basis, having to make a decision about whether I'm going to be somebody to attest for patients who come and ask me to sign their attestation. There are a lot of groups in the region that profitably serve as the medical marijuana doc, right? You come in and see them and you pay $200 and get that attestation, which is certainly difficult for our socioeconomically challenged patients. This is one of my favorite subjects to talk about. I think we could talk for hours about this. I think that, you know, on an individual and especially a resident level, it's absolutely appropriate to say no. I think it's way too early for us to say that you are likely to benefit from this. Not that attesting necessarily means you're saying that, but you are in some way sort of endorsing it, right? You're not prescribing it, which I think is an important difference, but I think it's absolutely appropriate for providers to say, I don't have enough evidence. I don't know enough about the literature, especially with respect to your situation. There is not enough literature to really adequately guide me in this decision. And so I don't think that signing a attestation and essentially endorsing you using marijuana is likely to result in the benefits that you're hoping it will. Now, there may be other benefits on mood and quality of life that that patient experiences, but in terms of their arthritic back pain, there's not evidence to support that at this point. So I think it's absolutely appropriate to say no. I think it's absolutely appropriate if you as an individual provider decide, I want to be somebody to, in the right situations, use this and are really familiar with the data and stay on top of it. I think it's perfectly appropriate to say yes. I don't think there are significant legal ramifications, but I think in terms of a residency clinic, especially a clinic that is often faced with chronic opioid therapy and all the challenges associated with concomitant chronic opioid therapy and marijuana use and the pain implications of that, the consequences and the challenges are numerous. And so I know PMG Northeast does the same thing. I think it's absolutely appropriate, and I think it's smart to not attest for those patients. But if as an individual provider, you're familiar with the data, you make that decision, I don't think there are significant legal ramifications for you federally, which is what I hear from a lot of providers. Yeah.
In the multiple sclerosis population, there's a great deal of neuropathic pain. Most of it tends to be peripherally experienced, toes, feet, fingers. And using cannabis oil really seems to help some patients.
Yeah.
Topical.
Yeah.
Topical.
Yeah.
I think you are doing patients with chronic diseases that are physically debilitating a tremendous disservice by having them take systemic cannabis. For instance, the age-corrected mortality for patients with multiple sclerosis is 3 times the normal population. 3 times. And almost all of it's due to obesity, cardiovascular disease, and lung disease.
I see, yeah.
So here you have physically underactive people, to speak nothing of what does to their balance when they're already ataxic.
Sure, right.
So I think that it is responsible and I think it is humane for people to attest for the use of cannabis oil. You can't limit that, I realize that, but that's why you're doing it. I think that's perfectly reasonable. And you know what? If it doesn't work, they're going to stop it.
Right.
Because it has very little systemic effect that has any psychological benefit.
Yeah. So the comment was about the use of marijuana, especially topical marijuana for neuropathic pain in patients with MS. The data is certainly more supportive of that. There is some support for oral cannabis extract in spasticity. And again, that's equivocal. But I think that it's absolutely true that you have to take into account all the other factors that are associated with your population.
One other thing. Gabapentin, pregabalin, these are not benign substances. They have very, very profound biological effects on people that in sustained long-term high dose can be very, very difficult. Thank heaven they're not opiates.
Yeah.
But over the long run, they create a profile of problems of their own.
Absolutely.
And if you can cut down on the use of those compounds, patients are better served.
Right. Thank you. So I'm happy to.
That we're at 9 in case some people need to step out. Interesting topic, so please feel free to continue to ask questions, and those who need to leave can leave.
Great. Yeah, please.
Craig, I want to ask whether or not I'm suspicious that we're going to need to broaden our definition of the cannabis hyperemesis syndrome. We see a lot of patients in the hospital who don't fit that classic pattern of those 100 patients, but who are still smoking, and it seems like we see more cyclic vomiting syndrome than ever existed in the previous 20 years.
Yes.
And I just wonder if you have that suspicion.
Yes. So the question is, the suspicion that, there's more cyclic vomiting that is occurring now than there was previously, and that there's maybe a significant association with, definitely a significant association with marijuana. I think we incompletely understand cyclic vomiting, and I feel reassured as a clinician when I can point to the marijuana and say, here's something I can counsel the patient on, because it's such a difficult thing to treat. And I don't think necessarily that we should ever limit it to the specific population that study identified or try and limit ourselves there. But I've found so many times where there's, I use marijuana once in a while, and we tend to think, well, maybe that's not the association, but patients who stop using it tend to get better. So I think being thoughtful about the influence of marijuana and being thoughtful about cyclic vomiting in general and what we can do to help that is really important.
I was thinking about the chronic pain patient that is on opioids, and then you, of course, find out or they test positive for marijuana. I've always thought, my opinion was, well, you have a choice. You can either use marijuana or opioids, but you shouldn't use both. And so if you're going to use marijuana, I'm not going to prescribe opioids for chronic pain.
Right.
What do you think of that?
Yeah, so the question is, what about those patients who we find through the urine drug screening, or we counsel them up front? You have to choose marijuana or opioids to make a decision about what you're going to use to treat your pain. I think that's a very appropriate stance to take, to say, I want you to choose one or the other, because for patients with chronic pain, it's really important that we offer limits, that we offer counseling, that we offer discussion around that. I have come around, however, on the idea that the marijuana may not be effectively treating the pain, and opioids are. And so for the appropriate patient population, I think it's okay to have both. I think having a blanket policy is challenging. I think it's important for a residency clinic to make a decision one way or the other to simplify the decision-making process, because there's toxicity associated with both of these, obviously. But I'm heavily involved at the Vancouver Clinic, developing clinical guidelines and clinical workflows to cut down on or achieve the lowest effective dose for opioid therapy. And we've taken into account marijuana use and all the factors that we can use to help counsel patients about toxicity and thinking carefully about achieving that lowest effective dose. And ultimately come to the conclusion that we let providers make the decision about whether or not the marijuana should be a disincentive or not. And I think you have to really look at every patient independently, because there are certainly patients with palliative needs who are going to benefit quite a bit from both. Yeah.
Yeah, your comments about marijuana addiction and withdrawal, are there objective signs that might be helpful, for instance, have objective signs of opiate withdrawal, and also about treatment of marijuana withdrawal or addiction?
That's a great question. So specifically, symptoms and signs of marijuana withdrawal, especially thinking about treating dependence and addiction. I think that the cravings are real. I think that that's something that patients are going to have who are withdrawing from marijuana. I don't know of any other specific physiologic signs, like we think of the piloerection and the sort of constipation and the sweating and everything else that comes with opioid withdrawal. But I certainly think that, and this is the case with opioid withdrawal too, there are subconscious, not easily identified signs and symptoms that patients feel that leads to an overall increased level of anxiety around this substance. I need to get this substance to feel better. And that anxiety exists with both of these substances, that I think it's the whole reason why I think Suboxone is so effective for chronic opioid therapies, because you're essentially placating those receptors and are able to essentially replace what was lost in the reduction of endorphins that comes from using opioids chronically over time. So I don't know of great physiologic signs to watch for, to counsel patients on, but I think just that overall general anxiety associated with missing your next dose or missing your next use of that substance, and especially if you've got evidence of the neurocognitive side effects, the decreased motivation to be engaged in other activities, the decreased functional status, I think those are all good reasons to refer for substance abuse counseling. Really good question. Yeah, thank you. Great, thank you.